I guess while we're trying to look at the slide, load up the slides or find the slides, I mean, maybe we can ask the panel, what do we think about the differences between stents so far? I mean, I think I have to confess, when we see all these presentations and see all the different trials, they seem very similar over time, the past few years, of all the different stents.
Yeah, I mean, I think a lot of the trials are designed for non-inferiority. I think the Orsiro data are interesting because it did look like, at least in the one of their pivotal trials, that they showed some data that was superior to the Xience. I think, you know, the issue with the Orsiro is that it's incredibly thin strut below 3.0. 3.0 and above, it's about the same. So I think you have to be a little bit careful. It's not a thin strut stent throughout the entire platforms. I think the thing that's really going to differentiate the stents now, and we've already started to see this sort of downward pricing pressure on them, is largely going to be pricing and how hospital networks negotiate those prices and with which vendors. Right now, for example, I mean, we're being limited to, you know, 2, maybe 3 vendors at the most. The idea, I think, as they become commoditized, is to reduce the number of platforms on the shelf.
Yeah, I agree. I think the numbers look pretty much the same, and from my standpoint, from our hospital system standpoint, it's just a negotiation with the companies, whatever we can get lowest price, because clinically they are relatively comparable.
I think most of us on this panel grew up sort of with the bare metal transition to the first generation. Well, maybe not you. Maybe not you either. But with the Cypher Stents and the Taxus and the difficult with deliverability and the sticking, I don't know if you guys remember that, where you couldn't get that balloon out.
Yeah.
And then we've really transitioned to these amazing, I guess they call them second generation stents, where deliverability is quite incredible, as well as visualization.
Yeah.
And I agree with Dr. Hall. I mean, if you look at the data, there's really no signal that's compelling of making a decision based on an efficacy or a safety endpoint. So it's really about the practicality of the stents and visibility and deliverability, and we're frankly quite spoiled. And so I do think we're at a point of diminishing returns with technology changes. I do think the bioabsorbable stent was exciting, although, you know, that was exciting for a year, and now it's I don't know what it's not quite.
Well, let me ask you this though. I mean, do you think that a bioresorbable polymer confers an advantage?
You know, again, I think theoretically it does in terms of the inflammatory effects of the polymer, and I think that it goes away. But practically speaking, in these trials, there's no obvious, I think, data signal. We use Synergy mostly in our lab, and it's not necessarily because of the compelling difference in safety or efficacy. It's because of sort of the ease of use and visibility, and we're used to it. And it's hard now, I really say, for the device companies to really have a compelling case to change besides pricing, really, now, which I think is good for the U.S. and healthcare expenditures.
Does anyone on the panel change their duration of DAPT based on the stent platform?
I would say, just a little comment. I'm a little concerned going very thin strut in certain anatomical subset, particularly very calcified lesions, particularly osteal lesions. I think there's something still to be said about the radial strength of the stent. So going below 90 to 100 microns, I think we do need to get a little bit more data in those subsets. But I think other than that, I do think the data is very similar. But regarding DAPT, no, I haven't changed my strategy in terms of duration.
I think for the DAPT, I mean, obviously in Europe they're using shorter duration. You know, in the US we were part of that, part of both the Boston trials and now the Xience short DAPT trials. So I guess it's best to have the data first. Though I think that in patients who have a high bleeding risk or unexpected surgery, I think we've been more comfortable stopping at 3 months. A lot depends on, I guess, the location, as long as it's not sort of left main, and also perhaps on the complexity of the intervention. So I think if you have a short focal stent, you feel more comfortable stopping it early. If it's something more complex at a bifurcation and perhaps a CTO, then perhaps we tend to go a little longer.
So we still have time for some discussion. So, you know, we talked a little bit while we were, you know, waiting for the second viewpoint about how some of these decisions get made, and largely it sounds like they're, for many of us, being taken out of our hands specifically and being done sort of at the system level. How many platforms do you guys have on the shelf right now in your labs?
We have two platforms.
Is that a mandate, or is it just something you've decided?
So we participate in some of these large bargaining type agreements, and one's through the Cleveland Clinic, where you basically make decisions sort of as a sort of 90 hospital system, and you get pricing, but you have input. I think we're three schools, right? There's interventionalists who want to use the newest thing on the shelf no matter what. There's those who don't really care and use whatever's there, and there's those that are conservative. And I would say a lot of us are conservative because if you have a dominant player like a stent that's worked well with good safety data, and I say long-term data, that's key. I think the bioabsorbable stent was an example of people were so ready to use it, but then when the long-term data came out, all of a sudden it's not deemed safe. And even the Promus, if you guys remember the Promus stent with the platinum chromium, there's that issue of that longitudinal shortening that was occurring, right? We tell the fellows there's no free lunch. You can't decrease strut thickness and get the same type of radial strength. And there was that big concern. And so I think that a lot of us were reticent and reluctant to use the new Promus until some of the longer term safety data came, and it substantiated that it was safe to use. But I think that's the trouble here, is sometimes you're so quick to use something when what you have is actually pretty darn good. And just like Dr. Hall was saying, it's not the shoes, it's the player. By the way, Quali, he's not at Toronto anymore. Sorry.
I'm at the VA. Unfortunately, we're not subject to those pressures. We get whatever we want. And so currently we have a few samples of this. So we have three different ones, the Medtronic stent and the Resolute in different sizes because they have specific sizes, the Synergies and the Sciences. So it's great to have, each one has a little bit of differentiation, especially the different sizes for the Resolutes. So that's why we have them.
We only have one platform, and it's mandated by the hospital system. So we get some say into what platform to use, but and if you have any preference, to be honest, though, the final decision really comes from the top, and it's financial.
We carry all three platforms. We've negotiated hard for that, but I don't see how we're going to be able to convince the administration to get a fourth platform on the shelf. And frankly, we're talking about different technologies that may have minute differences between them. It's definitely not mortality benefit that we're talking about, and most likely no hard outcome benefits. So it's really hard to kind of think about when do we stop to put a lot of these resources in a world where the resources are limited, put more money into research and to find only tiny differences. At some point, we may need to stop.
So I'm in the same hospital system as this Konstantinos Chaitakis. And we have actually all four, and we've also got the fifth one coming in the Eloneer for eval. But I think that's because our system, I think, is perhaps not as evolved as some of the others. I do agree that, we have to consider economic constraints, and probably the best thing to sort of come out of all these stents in the contemporary era is, the way the trials are designed, they're also good, is the fact of the price wars. I mean, I think it's maybe led to better pricing for some of these stents. Clinically, I think it's very hard. You'd be hard-pressed to actually, in daily practice, to say there's a difference. I think I do fairly complex cases, a lot of CHIP, CTO-type procedures, and really it's a matter of who's supporting that day. I will point out with the Orsiro that I think visibility does become an issue when you have multiple stents, and we've had issues where once we've gone back in IVUS and saw that we actually missed overlapping those stents. So again, I think that's one place where I would probably not use Orsiro, but short of that, I think all of these stents perform really well.
Yeah, we're a little lucky as well. We have all four platforms, including Orsiro, and I agree with what was said. I think the differences are minimal, and you can, potentially, hypothetically, use the difference in stent struts for certain anatomical subsets, and some stents are a little bit easier to put where the markers, where the stent is on the middle of the marker, maybe a little bit better for osteal lesions, but the differences are very, very minimal.
I think you're able to afford those four platforms because you're doing so much radial, Dimitri, in your lab. So
that's probably right.
Extra money laying around, you can buy the stents.
Just one final comment. So as a debate, I mean, it's an interesting debate. I think most of us, agree that probably on the differences. I think the real debate is, and to me, we may never win this one, is Lima versus DES. I mean, I think ultimately, where bypass wins, is when you have a Lima and some of these proximal LED stenosis or the left main, patients with complex disease, what stent do you use there, and will we ever have a stent to match the performance of a Lima? And I think that's sort of the future for some of these complex PCIs.
Yeah, that's a good point. St. John Park did have that one trial that was probably underpowered, showing no difference between proximal LAD PCI versus Lima using the first generation DES, which I'm going to let Arnold say something because I have another question that's related to that. Go ahead, Arnold.
Well, I was just going to add that the visibility issue is a serious thing because as our radiation safety has increased with the newer machines, our outputs on the X-ray machines are much lower. I cannot see the thin thread stents with, like we were testing out this Felty stent. Under fluoro, I can't see it anymore.
Right.
And so I'm using a lot more stent boost and some IVUS and
Sync Vision.
Sync Vision to help. Sync Vision comes with the the stent boost essentially. And so that's been very helpful. And I've never had to rely on that until I got to the Philips Allura Clarity, which had the low dose radiation. Yeah. So there's trade-offs in each of those.
Going back to the issue of proximal LAD PCI, I think one of the reasons why that trial showed one of the potential reasons why that trial showed no difference is obviously the sample size. But the other issue is the sort of routine use of intravascular imaging in that part of the world. In Korea, Japan, China, there's a lot of use of IVUS. In the United States, I think that the rate of IVUS is probably going up. If you look at the NCDR, it's still less than 10% of all the PCIs. And we could probably say that most PCIs, one could argue that you don't need it. But I have to tell you that once we saw the Illumian data, we started to do a lot more intravascular imaging, and it certainly changed my practice in terms of sizing and post dilation. I'm just curious, any comments about that? Whether it's the stent or the actual technique? I don't know if any of these trials mandated intravascular imaging. My guess is they probably didn't. Probably there was a sub-study because for the FDA you have to do that, but I don't think it was mandatory. And how much does the implantation technique affect some of these outcomes? Wissam, what do you think?
Yeah, I think this is where probably a lot of our research should focus, and we do have data that IVUS-guided intervention is superior or imaging-guided intervention is superior to non-imaging guided intervention. The question of the Lima, unfortunately, a lot of the studies are not done, but there was the hybrid trial comparing stenting versus Lima in multi-vessel disease, and this was stopped early for poor enrollment. So we still have a lot of work to do to understand these questions.
Sunil, here in the room, Stéphane Raifray here.
Yeah.
I haven't heard anybody talking about fluoropolymer because there's emerging data, and especially from CVPath, where they've actually looked at the anti-platelet effect of permanent fluoropolymer.
Yeah.
And they actually work. And you can see a real difference. So maybe the strategy of companies going to melt that polymer and disappear is wrong. And that may explain why the results with Xience and Promus were so exceptional. So I'm not sure if the polymer is always bad. Now, those ones were probably really good.
I think that's a great point. We talked a little bit about the whole issue of bioresorbable polymer. There is this hypothesis that the fluoropolymer may be somewhat protective against that. And I remember the early CVPath data showed a lot of eosinophilic infiltration around the first generation DES polymers, keeping in mind that the patient population that CVPath sees is very, very unique. They're all dead. So it's hard to know what to make of that. But I think your point is a good one, and it does sort of you have to think about the different components of DES. So what do you think, Konstantinos? I mean, do you think that the components of the DES matter as much now as they did before? Because you're talking about strut thickness, you're talking about radial opacity, you're talking about radial strength, you're talking about the drug, you're talking about elution kinetics, and you're talking about the polymer.
Right. Well, I think that, for example, the visibility is an issue. The cobalt alloy, it's much harder to see. So for certain parameters, it does matter. But I believe that the second generation drug-eluting stents we have today, they're really, really very good. And these are really subtle differences that I'm not really sure how it matters at the end of the day.
Did anyone have enthusiasm for BVS in the early days?
I think that gets to the question of this intravascular imaging. I think for sure, in my opinion, that IVUS enhances your stent implantation, your post-dilatation, and I think it's impactful. And I think it's hard in a clinical trial to bear that out. I think the BVS was an example of how that technology the first iteration required a tremendous amount of pre-dilatation and lesion preparations, that which is above and beyond what we're used to doing.
Yep.
And I think that was an obvious type of situation where if you didn't do it quite right and without a lot of enthusiasm and being very particular, you just weren't going to implant that stent correctly. And on a smaller scale, there's no question it's true for our stents that we put in today. So, I mean, I think a lot of us up here are doing IVUS probably, 99 out of 100 cases, and that's just our standard of care. But that really surprises me that the NCDR is still 10% of PCIs are using IVUS. So.
Yeah, and before we move on to the last debate, I do want to say one thing about that. So, I also say that it's not just about using IVUS, but knowing what you're looking at, because you have to do a certain number of chest wall echoes in order to be certified as a fellow, but we don't require that in the interventional space with respect to IVUS. So, we often see patients who are referred where IVUS was used, but it's pretty clear that they really didn't know what they were looking at and still undersized the stent anyway. Whether that's because it's misinterpretation of the images or they're afraid of getting a perforation. And sometimes I think, you do have to sort of swallow your pride. I mean, I did very, very little IVUS as a fellow, so it was really after I finished my fellowship. But I went to a course, and I still email people about some findings that I don't really know how to interpret in IVUS. So I think it has to do with using it and then understanding what to do with that information and how to interpret those images.
Well, first of all, I'd like to comment that you guys look a lot better in the pictures than in real life. That jumped out to
That
me.
we can all agree on, yeah.
But I would agree. I think it's radial first is the strategy. I think you both advocated for that, and I do think that the threshold should be different for everybody. I mean, your radial first should all have that what you're comfortable with the procedure you're asked to do, and it varies with everybody. But I would say for sure, as the fellows come through, that those who have been trained radially are not as skilled with femoral access. And I think the most well-balanced interventionalists is the ones who are doing complex procedures and using both the radial and the femoral access. And you cannot rely on one. What patients want the most, though, they want to be alive without complications. So you want your interventionalists to do the access they're most comfortable with, but I think interventionalists now contemporarily need to be skilled in both.
Yeah, it's July, and so I'm feeling this very acutely right now on training fellows. I think there's good reasons to think that the Campeau paradox is potentially real because it falls in line with what we all know, which is, doing more or something makes you better at it. So it kind of makes sense in that way. On the other hand, the data isn't necessarily convincing because you're not really randomizing these people. People who needed femoral, they're generally sicker. They had shock, they had a complication, they had a bad radial. So it's hard to tease that out, I think. And so you have arguments on both sides. I suspect it's real. I suspect it's something we should continue to train for. But it's the evidence isn't convincing.
Yeah, I also agree. I think it would make sense for it to be real, but the data is not that convincing. And also the data that you guys showed, the high complication rate in the high percentage of radial cases, it's possible those centers are just doing a lot more complex PCIs, and maybe that may be the reason why they're having more complications with the femoral. But I think there's still role for femoral access and safe femoral access, ultrasound-guided vascular closure, I think is very important. Micropuncture, because a lot of these trials that look at radial femoral, the femoral access was not necessarily done with that approach of a safe femoral approach. So the results might have been a little bit different, but I would agree that I think radial for most people and femoral in the few, like cardiogenic shock, et cetera, still has a pertinent role.
Yeah, I agree that it's hard to interpret non-randomized data, but I do share the concern that with the training these days, it's extremely important to train our fellows with femoral access. And I'm actually concerned that a lot of fellows that I see sometimes have little experience with femoral, and we should come up with some sort of solution for that.
I think all the points have been made. I think ultimately it's a matter of getting those 10,000 hours in for whatever you want to do. So, if you're radial first, you can train yourself to become a good femoralist. If you're femoral first, I think most of us were by force, we had to, acquire radial skills. Ultimately, it's being experienced enough with both to be able to do what you need to do. And where people really struggle is trying to understand the difference in how guides behave between the radial and the femoral access. So And EBU, I use EBU from both femoral and radial, but how I use the EBU guide depends really on the access, and it's different how I choose the size and shape and whatnot. So ultimately, I think it's a matter of being comfortable with what you do. And it reminds me of the debate that we have in our household when we go out, because my wife can't use chopsticks and my daughter refused to use a fork in a sushi store or a Chinese. So, which one's better, forks or chopsticks? I don't know. I think you better be good at both.
I can answer that for you. No, I'm joking.
All right, we're going to move on, but I'll say one thing about the Campo. I look at the Campo paradox as like the zombie apocalypse. It's not real, but it could be. So you better be prepared. So you got to learn how to get femoral access. So this is a great topic because this comes up all the time in our lab. So how many of you people on the panel are doing DK crush for all your left main bifurcations?
All of them?
Majority?
Or some of them?
Okay, so say most of them. Most of them. That's your preferred strategy.
For most of them, yes.
Okay. How about in the audience? How many people are using routine DK crush for left mains? So it's interesting. It's really not everybody. And as Manos outlined, I mean, the data are what they are. But it's a curious thing because it is one of the few areas where more stent at the carina seems to be associated with better outcomes, which does seem to fly in the face of what we have seen before with bifurcations. So, Tom, is it all about final kissing balloon? How do you reconcile that with some of the earlier bifurcation data that suggests that you don't even have to kiss balloons anymore? Remember the Nordic trial?
Yeah, I think Dr. Miraj's the most memorable slide to me is the one about the DK Crush 5 investigators. These are my countrymen in China. They average over 300 PCIs and over 20 left main PCI procedures. And for all of you that raise your hand out there, I doubt that 10% of you have those numbers. And in fact, the median number of PCIs in the United States is far below 100.
Oh, yeah.
And so the idea that you are able to perform a DK crush at the precision as my countrymen in China is just unlikely. And to Manos's defense, I've numbered the 9 DK crush on my computer, and I'll sometimes pull that up as I do a DK crush. And the only reason why it's 17 now, Manos, is because you've added stuff. And every time you look at DK crush, there's something more to add. Do you post-dilate the side branch stent first before you crush it? What size balloon do you use to crush it? Do you pot once, do you pot twice? And I think therein lies the issue. And to your point, Jeff Rubenstein out there, we do CTOs together, and we reviewed a case of a patient who came in with acute stent thrombosis where they did a DK crush strategy, and we actually reviewed the films, and we're like, that wasn't a DK crush. It was so far from a DK crush, but I had no doubt the operator wanted to do a DK crush but couldn't, and thereby left this patient with basically a side branch stent that was not kissing balloon, and just it shut down, and it shut down the main branch as well. So I really think that the efficacy is in the real world. The effectiveness is how does it really apply to the real world, and that's the key here. The efficacy of DK crush is true in China for those operators. The effectiveness is what we're sort of debating right now, is with the lower volume operators, lower left main interventions, are we really doing it the way that they did it there, and can you really expect for there to be superiority there? And I'd say no. And so I still think that whatever you're most comfortable with is what you should be doing, and if you want someone to get a DK crush-like result, then perhaps send them to, Manos is sending there in Minneapolis to where they're doing, 100 left main interventions a year.
I'll just say one thing before we go to Stefan's comment, is that we're in Colorado, you can do as much pot as you want.
And in Canada as well. Sorry to bug you again, but I wanted to say something. I think one of the problem with DK Crush 5 is also that their preferred strategy was DK Crush. When you're doing a tap procedure, the pot is extremely important, and if you don't image systematically, how many times I've seen people literally doing an internal crush of the the stent that's deployed at the end. So when you're doing a tap, it's a side branch last strategy. And if you go back with the balloon and you're not careful about the localization of your balloon, you will crush the stent that you've placed in the branch, and then you will make it a disaster. So I see that mistake being done over and over during live cases and everything, not re-imaged, and I think that might have influenced and led to the very unexpected bad outcomes with the TAP technique in that study. So before we just all conclude that this is how we should be doing things, look at how the French have been doing left main for about 20 years with super low rate of complication, with a provisional T-stenting strategy, but they understand what they're doing. They're not doing internal crush, they're bringing the stent right at the carina, and they try to respect. But if you do a neo-carina, this is very dangerous, especially if you go back and you crush it.
Yeah, that's a good point. I mean, I think there is this whole issue of technique, as you said, Tom. I mean, I guess the bigger question is if you're doing so few PCIs a year, should you even be tackling these left mains? That's really sort of a bigger question. Arnold?
Yeah, I was just going to say that, I think we should be cautious. I mean, it's definitely one thing to say that the Chinese have higher volume, and then left mains are going to be better at it and more practice. We always should keep in mind what Stefan said, though. If you're an advocate for a particular technique, you're an advocate for that technique, and your study may promote that more, and you might do the other techniques less well. And so while I love to say like my fellow countrymen, fellow Chinese are probably better than us in doing left mains, I will also invoke my Taiwanese nationalist mother-in-law who says that you really can't trust the Chinese either. So I think
Wow.
Yeah.
Wow.
I can say that because I'm ethnically Chinese, but I must stay out of that.
We're meeting after this later.
Yeah, so Sunil, I was going to say that, Q-Lot when it first came out, was on a different generation of stents, and that I would argue had just as many steps and was just as confusing and perplexing to us. So I think I would agree with Stefan. While I do a lot of DK crush, my second preferred technique is actually tap, and I think there's been a lot of crossover. I think what we learned from DK crush is, to Manos's point, that the value of the kiss, and kiss twice, kiss three times if you have to. I think what you learn from TAP is the value of pot, and I think ultimately it ends up being a hybrid type of procedure where you do DK crush, but you're potting much earlier on in the process and maybe using imaging after the pot to make sure before you put the other stent in. And finally, I think from my perspective, the simplified protocol is this. Go in and think, what's the likelihood of you fixing the side branch? If it's high, then have upfront decide to do DK crush. You have to have the stamina, and you just decide that it's not going to be a quick case. You have to spend your time on it.
I think we have enough evidence. I'm sorry.
I would just like to mention that it also depends on the kind of patient you have in front of you, I think. It's a different story if in the middle of the night a patient with critical left main comes in shock, and there you have to get out of there as soon as possible. But you're not going to do 17 steps in the middle of the night. Now, if you have a Impella 5.0 in and you have the patients early in the morning, and there I think you can take your time and do it right.
Yeah.
I think there's enough evidence that, at least in the United States, if you want to, for somebody who doesn't have a lot of experience, provisional stenting is still, in my mind, the way to go. And this is what we should tell people: the less stents, the better it is. But whether you do it or not, if you're going to learn two stent technique, I would focus on the DK crush, because it's the most guaranteed way to get a better result and to be able to get back in the side branches. With a culotte, you have that one step where you lose the wire into the main branch that could be tricky and could put you in trouble.
The 2 points, I think there is something to be said about it. If your volume is low and you cannot really do DK crushed or high volume centers, I think it's probably better for you to refer those patients with left main bifurcation to high volume centers for them to get the proper bifurcation strategy. Second point is, I think we talked about intravascular imaging. I think it may be very important also in bifurcation to apply intravascular imaging to optimize the stent results, and that may play an important role in bifurcation. I think DK Crush 7 or 8 is looking at the intravascular imaging and bifurcation in DK Crush bifurcation technique.
So Sunil, I'm actually going to marry this question to the question that the last debate asked, and ask that for bifurcation stenting and preferably for DK Crush, are all DES the same? What does the panel
I was just about to ask that question. That's a great question. Anyone want to take an opinion on that? Would you feel comfortable doing DK crush or any type of crush technique without any stent that's currently available, or do you pick and choose?
Maybe just go down the panel and see what people's thoughts are.
Manos, do you have a preference for which stent you use for DK crush, or are all of them pretty much the same? Yeah. Yeah. Yes, I don't know if people could hear that, but Manas was saying that the construction of the science has a little more open architecture to be able to access the side branch. But the other important thing is to remember which stent sizes can be expanded to which maximum diameter, because if you're dealing with the large left main, that's going to be important so you don't fracture the struts. In the last few minutes, what I want to talk about, we talked a lot about imaging. We talked about kissing balloons and the pot technique and then other types of pot in Colorado. But what? Let's talk a little bit about lesion preparation, because I think that's another aspect of this which I think sometimes gets ignored. Not all predilation is the same. Not all lesion prep is the same. So, anyone on the panel, tell me a little bit about your approach to some of these more complex left mains, whether they're calcified or not. How do you decide which type of lesion prep to use, and how do you know when you're ready to put the stent in?
So I'll make a quick. I don't want to take someone else's time, but I'll just say that this is something that Dimitri pointed out to when the stent debate. Most of the time when we deal with stent failures, because that's ultimately what the question is because of either underexpanded stents or stent recoil at an osteostenosis. So I think imaging is very key, and I think this is a place where you really want to modify the lesion either by atherectomy or using something like cutting or a scoring balloon up front. Now, how we decide when that lesion is prepped enough, I'll leave that to my colleagues.
Yeah, I think I'll make just a quick comment about DK crush is that I think for left main, it makes a lot of sense for majority of the lesion. I think the left main, when it's large, when the bifurcation is large, can certainly accommodate a lot of metal, whereas dealing with the bifurcation in the smaller vessel, it's a slightly different issue. So I would prefer and sometimes separate the bifurcations, whether they're in the left main or not, in terms of what approach you're going to take, in addition to the anatomy and angulation and the size of the side branch, of course. But in terms of the lesion prep, I think it's extremely important to determine how calcified, how severe the lesion is. But one way or another, you have to prepare the lesion well. So whether this is non-compliant balloons, which is typically what I use, whether it's some sort of an angiosculpt cutting balloon strategy, whether you need to do rotational atherectomy if it's a severely calcified lesion. I think at the end of the day, we need to prepare the lesion.
The most difficult bifurcations that fail most of the time are the heavily calcified ones. These cases, if you're not going to do rotational atherectomy or orbital atherectomy, you should at least inflate a non-compliant balloon to close to the size of the vessel to make sure that your stent is going to be deployed. You don't want to be in the middle of, after you deploy the stent, trying to post-dilate the stent that's not going up.
Yeah, that's a great point, actually, and I think it's consistent with what we've been saying all along. If you do 1 or 2 runs with an orbital atherectomy crown and say, okay, I've done atherectomy without testing the compliance, you really haven't done it right. And so again, it goes back to this whole issue of efficacy versus effectiveness. So I want to thank everybody for participating in this session. I think it's been a terrific session. I think some consistent messages have come through, and I hope that you all enjoyed it. Enjoy the rest of the conference.